Hello and welcome. Today we're diving into a fascinating and crucial topic, ureteral tuberculosis, a specific manifestation of tuberculosis affecting the urinary system. We'll explore its origins, how it impacts the body, how it's detected, and what can be done about it. Prepare to learn about this important, though often overlooked, condition. Ureteral tuberculosis, at its core, is caused by the bacterium Mycobacterium tuberculosis, the same culprit behind pulmonary tuberculosis. However, in the context of the urinary system, it's almost always secondary. This means the infection doesn't start in the ureter. Instead, it almost always arises from a primary tuberculosis infection elsewhere in the body, most commonly the lungs. The bacteria then travel through the bloodstream and lymphatic system, eventually settling in the kidneys. From there, the infection extends downwards, affecting the ureters. So, the root cause is always a Mycobacterium tuberculosis infection, but the ureteral involvement is usually a downstream consequence of the primary infection site. Now let's delve into the pathophysiology, or how this disease progresses within the body. Once Mycobacterium tuberculosis reaches the kidneys, it establishes itself and forms small lesions called tubercles. These tubercles can then erode into the renal collecting system. From there, the bacteria travel down the ureter. In the ureter, the infection triggers inflammation and the formation of granulomas. These are small masses of immune cells attempting to wall off the infection. This inflammation leads to scarring and fibrosis, which can narrow the ureter. This narrowing, known as stricture, obstructs the flow of urine. Over time, this obstruction can cause hydroureter and hydronephrosis, swelling of the ureter and kidney, respectively, due to the backup of urine. In severe cases, it can lead to kidney damage and even kidney failure. The whole process is a slow but relentless progression of infection, inflammation, scarring, and obstruction. The epidemiology of ureteral tuberculosis mirrors that of tuberculosis in general. It's significantly more prevalent in regions where tuberculosis is endemic, such as parts of Africa, Asia, and Eastern Europe. Individuals with weakened immune systems, such as those with HIV diabetes, or undergoing immunosuppressant therapy, are at a higher risk. Also, individuals who are incarcerated experiencing homelessness or have limited access to healthcare are also at a disproportionately higher risk of contracting tuberculosis, and therefore, ureteral tuberculosis. The signs and symptoms of ureteral tuberculosis can be varied and often mimic other urinary tract conditions, making diagnosis challenging. Common symptoms include frequent urination, painful urination, blood in the urine, hematuria, flank pain, and back pain. Because it is almost always secondary to pulmonary tuberculosis, patients may also present with symptoms such as a chronic cough, fever, night sweats, and weight loss. In advanced cases, symptoms related to kidney damage may appear, such as swelling in the legs and ankles, fatigue, and decreased urine output. Many times patients can be asymptomatic until advanced ureteral strictures are present. Diagnosing ureteral tuberculosis requires a multi-faceted approach. It often starts with a thorough medical history and physical examination, paying close attention to risk factors for tuberculosis. Urine tests are crucial, looking for the presence of bacteria, blood, and white blood cells. A urine culture can help identify Mycobacterium tuberculosis specifically. Imaging studies, such as an intravenous pyelogram IVP or CT urogram, are essential to visualize the ureters and kidneys, identifying any strictures, hydroureter or hydronephrosis. A cystoscopy, where a small camera is inserted into the bladder, allows direct visualization of the ureteral openings and bladder, and allows for biopsy of any suspicious lesions. Biopsy specimens can be sent for histopathology and culture to confirm the diagnosis of tuberculosis and rule out other potential causes. While ureteral tuberculosis doesn't have specific subtypes or classifications beyond its anatomical location, the severity of ureteral involvement can vary. Some patients may have minimal ureteral involvement, while others may have extensive strictures and significant kidney damage. The extent of disease is assessed during diagnosis and guides treatment decisions. The primary treatment for ureteral tuberculosis is antimicrobial therapy with anti-tuberculosis drugs. This typically involves a combination of several medications, such as isoniazid, rifampin, pyrazinamide, and ethambutol, taken for a period of 6 to 9 months. The specific drug regimen and duration will be determined by a physician based on the individual patient's case. In addition to medication, surgical intervention may be necessary to address ureteral strictures or significant hydronephrosis. This may involve procedures such as ureteral dilation, ureteral stenting, or in severe cases, ureteroneocystostomy, a surgery to reimplant the ureter into the bladder. In extreme cases of non-functioning kidneys, a nephrectomy, removal of the kidney, may be required. Preventing ureteral tuberculosis largely relies on preventing tuberculosis itself. This includes vaccination with the BCG vaccine in areas where tuberculosis is common, early detection and treatment of active tuberculosis cases, and public health initiatives to improve sanitation and reduce overcrowding. Screening individuals at high risk for tuberculosis, such as those with HIVs or close contacts of active TB cases, is also important. Finally, the latent TB infection can be treated prophylactically with isoniazid for 6 to 9 months in those who test positive on the skin test. The prognosis for ureteral tuberculosis depends on several factors, including the extent of ureteral involvement, the timeliness of diagnosis and treatment, and the patient's overall health. With early diagnosis and appropriate antimicrobial therapy, many patients can achieve a full recovery. However, delayed diagnosis or inadequate treatment can lead to significant kidney damage and even kidney failure. Recent research has focused on developing more effective and shorter duration anti-tuberculosis drug regimens, as well as improved methods for early detection and diagnosis. Additionally, ongoing research is investigating novel approaches to prevent and manage ureteral strictures, such as the use of biodegradable stents and anti-fibrotic therapies. Advances in surgical techniques are also improving the outcomes of reconstruct procedures for ureteral tuberculosis. We hope you learned a lot about ureteral tuberculosis today. Remember, early detection and treatment are key.